So I've been working for Radboud UMC now for over 16 years, and I've been involved with research in pregnant women since then. Well, pregnant women with HIV actually. And the title is A Wonderful Journey from Conception to Delivery and Beyond, what is going to happen after I leave this department. Yeah, so these are my disclosures and the content of my talk. Because not everybody is very familiar with pharmacology in pregnancy and pharmacokinetics, so I'll give you a short introduction about that. Then the conception of the Penta study and the gestation period, which is very long when you're talking about the Penta study, and about deliveries. And there's not only one delivery, but there are multiple ones, and also our new plans. So in general, pregnant and breastfeeding women are excluded from clinical trials. That's what most of you already know, especially during the development phase of a drug. And that leads to knowledge gaps when the drug comes on the market. We don't know anything about the pharmacokinetic changes. Do we give the right dose? That's important. I'm going into that more in detail. Does the drug cross the placenta? Is the drug safe for the fetus? And does the drug transfer into breast milk? So that's all things we don't know when the drug comes on the market, but pregnant women still take these drugs. A very short introduction about pharmacokinetics. What is pharmacokinetics? Because that's what I'm going to talk about a lot in this talk. It's what the body does to the drug. And what we describe is the study of the time course of drug absorption, distribution, metabolism, and excretion. And what we usually collect is blood samples, and then we make these nice curves. Most of you have seen them before. On the y-axis, you see the blood concentration. On the x-axis, it's the time after dosing, and then you see a nice curve over time. So the concentrations go up and go down again. And what we aim for is the blood concentrations to be within this therapeutic range. So we don't want them to be subtherapeutic because then the drug doesn't work, and we don't want them to be too high because then you will get adverse effects. And subtherapeutic drug concentrations in the context of HIV could also lead to resistant virus. So that's not something we want. So what is happening in pregnancy? There's a lot of changes that could affect the pharmacokinetics of drugs. So I've developed this slide a couple of years ago. And here you can see what the influence of pregnancy is on, for example, absorption, gastric pH increases, gastric emptying decreases. Women also get nausea, so they could, because of vomiting, the absorption is also less. The distribution, the volume of distribution can change. So women will be bigger during pregnancy, so there's a bigger volume for the drug to distribute over. And also the ratio between body water and body fat changes. So that all influences distribution of the drugs. Then on the right-hand side in the red boxes, you see what happens in the metabolism side. So cardiac output and also hepatic flow, blood flow increases. And enzyme activities also, usually for most enzymes, it increases. So the drug is broken down more quicker than normal. And in the elimination or excretion phase, also the renal excretion is increased. And I also want to show you this nice slide, which was sort of borrowed some information from my slide, but it's a much nicer, which was developed by Catriona Wade and her team. And what the overall effect is, often it's lower exposure during pregnancy, but exposure can also be higher. We'll see that later. But the main question is, should the dose be adapted in pregnancy? And that's what David Berger thought about in 2008. And then he hired me. You can see him as a very young person here, and me playing my horn. I'm still playing my horn, but you can see I was younger because you can see I've got different glasses. The rest is quite similar, I think. So David thought, well, we have to do something about that. We don't know anything about pharmacokinetics of ARVs in pregnancy, so let's start a study. So we said, he found me to write a protocol. So we set up the study on pharmacokinetics of newly developed antiretroviral agents in HIV-infected pregnant women. And we called it the Penta study. And we really developed a really nice logo, I think, with the little fetus in the A. And Mark will also tell you that we have stolen the idea from the Impact P1026 study, which is maybe a little bit true, but they were doing that study in the United States, and we were going to do that study in Europe. And that might be a different patient population. Without money, we couldn't do that study, so we were looking for money, and Penta and Merck were the first one to financially fund the Penta study. So how do we study this pharmacokinetics in pregnancy? In the Penta and Impact study, it's quite similar. We use an opportunistic design study. Women already use the antiretrovirals for treatment of HIV in pregnancy. So we're looking for women who are already on these drugs. Then we ask them to come to the clinic during the 3rd trimester for 1 whole day, and we collect a pharmacokinetic curve. So the same curve as I showed you before. Where was my mouse? Anyway. So we collect that curve in the 3rd trimester of pregnancy, and we also collect that after delivery. And we ask the women to come back 4 to 6 weeks after delivery. And that curve is the reference curve. So that we say, okay, all these pregnancy effects have gone. And this is the normal situation again. And we compare these curves. I'll come back to that later. During delivery, we also collect a cord blood sample to assess whether this drug crosses the placenta, because when you remember, that's also something we don't know when the drug comes on the market. So this is a sample schedule we use in the Penta study. So we collect multiple samples after oral dosing. That's the upper bit of the graph. We take 10 samples over 24 hours after the oral dose, and then just before the next oral dose. And the lower bit of the graph, you can see the sample schedule for the new cabotegravir piferin, long-acting injectables. That's totally different, but it's also a curve. But we take 1 sample just before the injection, then 3 days after the injection, 7 days after the injection, 28 days, and 56 days after that injection. And that's also just before the next injection. So the women don't have to stay in the clinic, but they come for multiple visits. And how did we arrange all of this? So we have written a study protocol, of course, and that was submitted to all the ethics committees. What we do is when a new antiretroviral comes on the market, we write an amendment to this study protocol and just continue and add the new drugs. You could call it an adaptive trial design before, I think it was known of. At the moment, we are at Amendment 7 and Protocol version 8 of the Penta study. But as you know, I think Nijmegen is in the Netherlands, and the Netherlands is a small country, and we don't have many women living with HIV, let alone women who are pregnant, living with HIV, using the drugs we were looking for. So we set up this Penta network with multiple sites in multiple European countries, as you can see here. And our last site that was included is in Willemstad on Curaçao, which is in the Caribbean. And I was very lucky that I could visit all the sites at least once. So I've been to Curaçao this year. So that was really nice. And we've got other collaborators as well. So we are working together with the Impact study. As I told you, they've got approximately the same design as the Penta study. And for drugs, both of our studies only had a few patients included. We decided to join the data and and make joint publications. And we also work on population PK. So then you've got a bigger data set to build a population PK model on. And we also collaborated together in the WHO Impact Workshop on pharmacology studies in pregnancy. Next to that, we also work together with the pharmacology and toxicology department of the Radboud UMC. You see Rick Kreupink and Frans Russell here from that department. They were doing placental perfusion studies, which I'm going to show you a little bit later. And they were also into the physiologically based pharmacokinetic modeling. So it's a very special computer modeling system. And we were working with them as well and also published together. Without money, trials are not running, so we try to find funding for the Penta study. And Penta is an ongoing financial funder of the Penta study. And these pharmaceutical companies, Merck, Janssen, ViiV, and Gilead, also funded our studies for several drugs they marketed. So over time, when did we start? So we started in 2008 with developing a protocol. And in October 2009, we had our first inclusion in Rotterdam on raltegravir, I remember. And here is a cumulative patient inclusion graph. And in 2024, we are at 216 inclusions. And I think at the moment, 213 deliveries. Because all the people, most of the patients already delivered, and I think at the moment 3 are ongoing in the study. This is another graph looking at the inclusions in the Penta study. So we aim to include 16 patients per compound. On the x-axis, you see the abbreviations of the compounds within the Penta study. And the orange bars are the arms we already closed, we already published on, or we had another reason to close the arm. And the green bars are still open for inclusion. So you can see bictegravir, we've got 16 inclusions, but due to COVID, we had 1 inclusion who didn't have any curve taken. So we are still open for 1 or 2 patients. And raltegravir once daily and cabotegravir rilpivirine injectables and doravirine are arms that are still open at the moment. In total, as I told you, we've got 216 inclusions and no HIV transmissions. I think that's also good to mention here. Now about the trial sites. It's quite difficult to find patients who are on certain drugs, are pregnant and are willing to come to the clinic for a whole day during pregnancy and also postpartum. But here you can, so most of the sites only included like between 10 and 15 women. But you can see Brussels is really the top recruiter of our Penta network. And also the sites in Spain should be mentioned. I think Granada and Barcelona are quite high up there. Now let's talk about the results of the Penta study. What do we study and what does it mean? So you can see here a concentration time curve, like I showed you before. And this is the geometric mean plasma concentrations of bictegravir within the Penta study. So you can see the blue line representing the concentrations during the 3rd trimester, and the orange line is the postpartum exposure. And you can imagine that there is really you can see that there's quite a big difference. So we see a lot lower concentrations during pregnancy compared to the postpartum normal curve. And what we do is we calculate the area under the curve for both scenarios, so the pregnant and the postpartum scenario for every person. And then we divide this, we calculate a ratio of the AUC in pregnancy divided by the AUC postpartum. And from all these individual ratios, we calculate a geometric mean and a confidence interval. So the next slide shows 16 years of work in one slide. So here we see for the area under the curve, which is an important pharmacokinetic parameter representing exposure, total exposure, for the different antiretrovirals we have been studying. And you see the line of 1, which means that a ratio of 1 means that there is no pregnancy effect. But you can see that for most of the antiretrovirals, the geometric mean, which is represented by the filled circle, including the 90% confidence intervals, are left of this line, of this little dotted line of 1, which means that there is lower exposure during pregnancy. But you can also see that most of these bars are blue, which means that it's not clinically relevant. But a few of them are not blue. So you can see that elfitagravir is reddish, which is clinically relevant decrease in pregnancy, and rilpivirine is orange, and we think it's relevant, but not all guidelines agree on that. You can also see, as I told you before, we can also have higher exposure in pregnancy. That's what happened with etravirine. You see that all the confidence interval is to the right of 1, which means that there's higher exposure in pregnancy. And that's because the specific enzyme 2C90, CYP2C19, that metabolizes etravirine, is inhibited during pregnancy, so it doesn't work as hard as normal. But we also always look at a PK parameter in HIV is the C trough, which is the concentration, the plasma concentration just before the next dose. And here you can see that even the differences in pregnancy, or the pregnancy effect, is for most of the compounds, it's bigger than for the total exposure. And here you can see clearly that elfitagravir is very important. Why you cannot give it? Because it's clinically relevant. You see that almost 80% lower concentrations are reached in pregnancy. So are we the only ones who think that it's clinically relevant? No, it's also in guidelines and also in the label, I think. Elfitagravir boosted with cobicistat, avoid use in pregnancy due to the risk of treatment failure and maternal to child transmission of HIV because of the lower exposure to elfitagravir. But results of ARVs doesn't matter. So for most antiretrovirals, it is not that important, but for some, it really is important. And especially all the cobicistat boosted antiretrovirals, and also think of darunavir in that context. Pharmacokinetic changes are not the only things we look at within the PANA study, but we also investigate whether the drugs cross the placenta by taking that cord blood sample during delivery, and also take a maternal blood sample, and then we calculate a ratio between the cord blood concentrations and the maternal blood concentrations. Here you can see this, the different classes of antiretrovirals in different colors in this graph. And when you look at the ratio of 1 in this case, that means that the concentrations in the cord blood, so also in the fetus, are the same as the concentrations in the mother. And that means that the drug crosses the placenta very well. And for the integrase inhibitors, you see that mostly the ratio is above 1. For the NRTIs, the ratio is between around 0.8. Emtricitabine, although has very good placental transfer, NNRTIs, but the same as NRTIs, and protease inhibitors hardly cross the placenta. And also TAF, we were not able to see any TAF levels in the cord blood, but we do see tenofovir, so the active metabolite, of TAF in cord blood at the same to the same amount as when you give TDF to a pregnant woman. So what have we delivered? Well, we have presented over 30 posters or presentations at international conferences, and we have also published 23 publications. And 4 of these publications were together with the impact group. We published together on maraviroc, on etrovirine, efavirenz, and also a POPPY modeling study for darunavir, ritonavir. And where did we publish? Well, up till now, 8 is the main journal, but hopefully CID will follow with 7 papers soon as well. We are also very proud that our data are being used to in the guidelines. So the DHHS guideline, perinatal guidelines, uses our data and refers to our data. And also the BIVA guidelines, the perinatal guidelines for pregnancy and postpartum, also use our data to give advice to doctors and women who are pregnant and living with HIV. And we've got 3 PhDs that finished on the SPANA study. So the first is my thesis, and I graduated in 2015. The second one is Stijn Schalkwijk. He graduated in 2018, and the last one up till now is Vera Buckums, and she finished, I think, last year in 2022. I'm not sure. And Stijn and I both won the best thesis of arts in 2015 and 2018 from our university. Most of you have seen this slide before, I think. Well, Stijn Schalkwijk developed it for his thesis, actually. And this is the slide for the which represents the red circle represents drug approval. Then the blue circles represent and the numbers with that represent the years after drug approval. The first PK data in pregnancy were published. And this is the situation of the antiretrovirals we knew something about PK-wise in pregnancy when the PANA study started in 2009. And you can see that the median knowledge gap was 5 years at that moment between drug approval and getting the first PK data in pregnancy. But a lot of ARVs, we didn't have any data. So for efavirenz, darunavir, maraviroc, raltegravir, etrovirine. And also, that is important for the PANA study, a lot of drugs were registered after 2009. So for dolutegravir, rilpivirine, bictegravir, etc., etc. But what is the situation now? So we've got a lot more information. So dolutegravir, rilpivirine were added, TAF, bictegravir. But still, this median knowledge gap is still 5.5 years. Is that good enough? Well, we didn't think so. So we, together with WHO and Impact, we organized this working group and workshop to optimize pharmacology studies in pregnant and lactating women. And we really wanted to accelerate that, to getting these data earlier. And also after the PK based workshop, we also started to have this bigger workshop, which was about more general research in pregnant women with HIV and getting these drugs earlier and getting information earlier. So this is the really nice group of ladies I worked with for that workshop. And did it work? Yes. So we wrote a call to action, and the pharma industry, because they have to do it, they have to start doing studies earlier and include women who are pregnant and with HIV and in their clinical trials with newer drugs. or keep them on the newer drugs when they become pregnant during the phase 3 study, for example. And that's really happening at the moment. So I'm really proud that this is going on, because we are moving forward. Gilead already has some information about pharmacokinetics of bictegravir in their label. At IAS, 2 studies were presented. For example, so the sub-study of the HPTN 084 studying cabotegravir long-acting in PrEP, and Mark Mazinke showed the results of, at that moment, 50 PK curves in pregnancy already at IAS 2024. And we also heard from the Purpose 1 study at IAS with lenacapavir as a PrEP option, which was very effective, 0 infections. And they also had 184 pregnancies in that study, and they are also collecting pharmacokinetic data. So it's moving forward. Cabotegravir has already been registered, lenacapavir not yet. So we probably have pharmacokinetic data before it's registered for. Yeah. So the future, well, I'm going to disappear, not from the earth, but as we were talking about, but I'm not going on with the Panna study, but David Burger and Wendy van der Wekke will. And we also started already with the Panna B study, also a very nice logo with the, you can imagine what we're doing, breastfeeding. So what is there still to do within the Panna study itself? Well, you saw that we have still some green bars over there. So bictegravir, we still need 1 or 2 inclusions and publish the data. For doravirine, we already started talking about the collaboration at CROI last year, and we'll talk about it next week further with the Impact and Impact group and Angela Colbers, who is doing research in pregnancy with doravirine. And because we all have only a few women in pregnancy or breastfeeding, we want to collaborate and join and combine our data. For cabotegravir and rilpivirine, there's a way to go. For CAB, we probably know enough of pharmacokinetics in pregnancy after Mark Mazinke's presentation and publication. But rilpivirine injectables is another problem, because as you saw, we think that rilpivirine levels decrease during pregnancy, and does it decrease a lot during pregnancy when you give it as an injectable? So we still need to get those in vivo data. Then lenacapavir, do we still need data in Panna? Not sure. Other new ARVs, when pharma is going on as they are doing now, I think maybe not, but maybe we've got other options. Because since a couple of years, also in the higher income settings, women with HIV are allowed to breastfeed. So what we are interested in is how much of these drugs they are using, of these antiretrovirals they are using, get into breast milk. And this is the same graph as I showed you for pregnancy and pharmacokinetics. And this represents the concept, the information we've got of pharmacokinetics in breast milk. Median knowledge gap, 8 years. So that's even longer than in pregnancy. And be aware that we do have some data, as you see here, but most of them is only of a few patients. So it's collected in clinical practice, therapeutic drug monitoring. So only 1 sample per patient usually. And from a lot of drugs we don't know yet. So what are we doing about that? Well, we study it in 2 different ways. So we have a study which is called the Panna B TDM study. We are doing within the Netherlands, and we ask. There's also a study where we are looking for women who are breastfeeding, living with HIV, and use antiretrovirals. And we ask them to come to the clinic, or when they are in the clinic anyway, because they have to have the checkup. We will ask them to collect one milk sample. We'll collect one mother blood sample and potentially one child sample as well. One at 1 month, 3 months, and 6 months after delivery, if they are breastfeeding for that long period. So they can also only participate for the 3 months study. So that's one thing we are doing, but we're also studying intensive sampling, breast milk and blood sampling, because as you can see on the right-hand side, you see a graph also with concentration time curves, but the open circles are the plasma concentrations of a drug, and the squares, the black squares, are the milk concentrations. And what we calculate is a milk plasma concentration ratio, same as we do for cord blood. But you can see that after that it probably takes some time for the drug to transfer into the milk. So this milk plasma concentration differs over time after dosing. So it can be lower than 1 in the beginning, but higher than 1 at the end of the dosing interval. So what we are doing, that problem can be prevented by collecting a full pharmacokinetic curve over time. And that's what we are doing in the PANA-BPK study, and also within the PANA study, because within the PANA study, within the last amendment, we allowed women who are also who come for the postpartum visit and also are breastfeeding to also give us some milk samples. So we've got a full pharmacokinetic curve in blood, which is the purple tubes, and we also take a curve in milk. They have to pump the whole milk, and then we'll get a sample. And we do this in the PANA study, but also in the PANA-BPK study in healthy volunteers. So that means that we ask healthy women who are breastfeeding to come to our clinic at the end of breastfeeding period, usually, to take one single dose of an antiretroviral, and then we'll collect these samples over 24 hours. And then we can calculate these also this really good milk plasma concentration ratio, and we can do that of compounds that are not often used in clinical practice, because we won't see them in the TDM study. So that's why we are doing this in healthy volunteers. But there are also alternative methods. So I've been talking about in vivo studies, but we can also study the pharmacokinetics in pregnancy using physiologically based pharmacokinetic modeling, for example. That's what we have been doing. So in the second graph from the left shows this really fancy model. What we do, we put the chemical data for the target drug into the model, and the model represents the body in silico, so all the organs and all the connections with blood flow, and also in the liver there is also the abundance of enzymes, how many enzymes are there. And you can also see in the bottom bit that there is a placenta and a fetus in this model. So we really can even predict what the fetal concentrations will be during pregnancy, and you can predict it during whole pregnancy. And because this model is also adapted for pregnancy over gestation. So the changes I explained to you in the beginning are in this model. So enzymes work harder during the 3rd trimester of pregnancy. So that's all in this model using equations. But for the placental transfer, we need some information. And that's what our colleagues at the pharmacology toxicology department do. They do this ex vivo placenta perfusion model. So what they do is they get fresh placentas of healthy women from the ward just after they've been born, and they keep them alive for 3 to 6 hours. And you can and then they infuse, then they put cannulas in, as you can see, and on the right hand side, and that is a placenta. In one functional unit, which is a cotyledon, they put cannulas in at the maternal side and also at the fetal side. And then you infuse start infusing the maternal side with a solution with a concentration of an antiretroviral, and you collect samples from the fetal side. So you can see how much of it goes from the maternal to the fetal side. And in another placenta, they can do it the other way around. So from fetal to maternal, and then we can calculate a good ratio to put into that model. So we have been doing that before. So for Daravirin, we have done some predictions. Now we have to find out whether it's true with the in vivo studies. So what we predicted is that we would see up to 55% lower exposure in pregnancy for Daravirin. So we're really looking forward to see whether it's really with the in vivo studies, whether we really see that is the case. And also for breast milk transfer, same models can be used. So we've got this this model including a breast as another extract compartment. So then you can predict what the concentrations in breast milk would be, and then the next step could be dosing an infant, a baby, with this concentration of the drug. So that's what we are doing as well at the moment. So this is a summary of the Penta study and network. How did it go? 2008, our first meeting at the PIM in San Servlo with a couple of investigators where we developed the clinical trial protocol. Then in October, 2009, first inclusion in Rotterdam. 2011, first poster presentation at the International Antiretroviral Pharmacology Workshop. In 2013, our first publication in AIDS, that was TDF and emtricitabine, I think. My PhD was in 2015, and 2023, we included collection of breast milk in the Penta study protocol and also cabotegravir piferin long-acting. So what are the take-home messages? Well, pregnancy does cause potentially clinically relevant pharmacokinetic changes. In most cases, lower exposure is seen in pregnancy. Most drugs cross the placenta, integrase inhibitors more than NNRTIs and NRTIs, and protease inhibitors hardly cross the placenta. In silico modeling can help to predict PK changes in pregnancy and also fetal exposure, but we still need in vivo confirmation. So I think there's still some room for pharmacokinetic in vivo studies, but maybe we can include less patients. That's an option. And no one can play a whole symphony on a French horn. It takes a whole orchestra to play it. So, thanks to all the women who participated and all the Penta investigators and research nurses and coordinators, of course. And I want to name a few, but there are many more actually. But I want to name a few: Graham Taylor, Pepe Molto, Carmen Hidalgo, and Jürgen Rockstow. They all were involved from the early years of the Penta study. And of course, Deborah Konopnicki as the top recruiter from Saint-Pierre in Brussels. And Klaartje de Kanter and Diederik van der Wetering as our newest site in Willemstad, who already included 3 patients, and the 4th one is coming along. And but there are many more who were involved in the past and currently are involved in the Penta study, of course. And also want to thank the laboratory technicians of the Department of the Pharmacy. There will be a long list now, so be prepared. The impact team already mentioned, as this, I already mentioned the senior ones. I didn't name them actually, I think. So Mark Mirochnick, Brookie Best, Edmund Caporelli, and our current collaborators who are taking over from them, Christina Brooks and Jeremiah Mompa. Our colleagues from the Pharmacology and Toxicology department, and they joined our department even, so they are a division within the pharmacy department now. The PhD students on the Penta project, Stijn Schalkwijk, Vera Bukkums, Wendy van der Wekke, and the PhD students involved in analysis and papers who did their PhD on certain drugs or something else, Mare Blank, Pauline Bolle, Jolien Frederiksen, and Laura Nijboer. And of course, Monique Haukens for data management support. Then without the money, as I told you, we can't do anything. So pharmaceutical partners for the financial support and trust. Thank you. And Penta for the ongoing financial and scientific support. And Zon and Bay, they funded an entity within the Netherlands funding the PANA-B study. But almost last but not least, David Berger for giving me the opportunity and setup of the coordination of the PANA study. I think very good team, David. You can see it from our pictures. And the last one, he's already on the left-hand side picture, Carlo, and in his interesting, fantastic gown during my PhD defense for the trust from the beginning. So that was my presentation. I hope it was not too long, and I'll stop sharing my screen.
Angela, I was honored to be asked to talk during this session, but I was also saddened because we'll miss you very much. For people who don't know me, I've been the chair of Impact P1026S since its inception in 2003. And I think the real truth about the start of Penta, of PANA, is that David Berger used to come by our posters at Croy in the early years, and every year he would come by and look at his data, at our data, and then he would sort of mutter under his breath, 1026S is such a good protocol, Mark, and then he would walk away. And this happened for a couple of years, and then the next thing we heard was that PANA would be starting a protocol modeled on 1026S. So it's commonly said that imitation is the greatest form of flattery. So we took that as a compliment, but we were kind of worried. Who were these people who were going to be doing the same thing we were trying to do? Were they going to be rivals and competitors? What was the relationship going to be? And I'm pleased to be able to say that none of those bad feelings ever came to pass. And instead, David did the smart thing, which was to put you in charge. And you've always been a colleague and a collaborator and approach things in that sort of spirit. So we were able to support the two protocols. We were able to support each other. We combined data when the opportunistic approach didn't provide enough participants for either of us to have a sufficient number to publish independently. So we did that, as you said, from Araviroc and etravirine. We were able to combine data from fully enrolled arms in both our studies to do additional analyses, PopPK analyses done by Stein for efavirenz and darunavir. And then we became collaborators in a wider sense when we both became involved with the WHO Pediatric Antiretroviral Working Group, the POG, which moved from just pediatrics to also including perinatal topics, and then became colleagues and sponsoring meetings and putting out publications about the importance of studying drugs in pregnancy and especially HIV drugs, and finally moving the needle a little bit, as you discussed in the end of your talk, to now drug companies are not only giving us lip service about how important it is to study drugs in pregnancy, but are actually doing it in some of their new studies for newer agents. So I don't think it's putting 1026S, which now has been superseded by 2026, in the Impact Network. I don't think we're putting it 2026 and PANA out of business, but I think in a sense, the research area is opening up, and we have new colleagues who are interested as we are, because the same thing that motivates us, I'm sure, is what motivates you, is to get the PK and safety data on antiretrovirals and other infectious disease drugs in pregnant people available as soon as possible after licensure, so that clinicians aren't faced with the awful decision of trying to decide between using what is probably the best and newest drug for a clinical condition in a pregnant person, but worrying because there's no PK and safety data. And that's been our motivation all along, and we were so pleased because it was your motivation as well. And so, as I've said, over the years, we became collaborators and colleagues, and then more than that, we became friends. And it's been a pleasure to work with you. And while I'm sad that we won't continue to be working directly in the future, I do hope that in your new position, we'll be able to continue to interact. And it makes me, I take some confidence in knowing that someone with your background and your motivation and your skills and training will be making some of the decisions and hopefully pushing things along on the regulatory side of things, so that we'll be able to further this common goal that we share. And as David said, some of our other 1026S colleagues are on the call: Brookie Best and Edmund Caparelli, Tim Cressey, Tim seems to have his foot in every world. He's a member of the 1026S team, and he's 2026 team, and he's also part of PANA. He's on, and if they have anything to add, I welcome them to unmute and say a few words.
Thank you, Mark, for these very nice words and giving a summary of indeed what happened over the last 16 or 20 years. And I think it's a very good lesson to everyone that it's not always about competition, but it's really about collaborating and expanding data sets. And confirming observations from one study to another study, and I think that together that is a very good example of how two different networks can really work together and move the field ahead. So I'm very happy with your words and your comments, and of course the collaboration, which will not end, of course, with Angela leaving our department.
David, I see that Edmund has unmuted.
Yeah. So let's see. So is it Edmund? Yes.
Yeah, and besides echoing Mark's comments on how, maybe expanding on how collaborative the relationship has been initially with David, and more subsequently with Angela. This is one of the things we've always looked forward to at CROI meetings, is getting together and seeing where things are going, not because we want to steal each other's ideas. There's more than enough questions to answer in this space that we want to make sure that we're filling them. And it may not have been emphasized, but a lot of these studies have different elements. I mean, it's not just different populations and slightly different structures. There are different, maybe not the primary question as much as secondary questions, but I think those are going to be more important as we go into the long-acting agents, where the study designs are complicated, as well as in the breast milk space, where I think Angela nicely pointed out that the time of sampling is important. We always do that with plasma PK. Obviously, that's a part of it, but there are also going to be issues with the body, with the breast milk composition, the time at which they are in pregnancy, as well as the other thing our group, and this is a broader statement, is these drugs may affect the breast milk composition. So the complicated area, we want to do the best for the health, obviously the mother, We want to help prevent transmission, to the extent possible. And I think a lot of the data that's been generated out of Penta really does help in that regard. But, as well as the long-term, short and long-term, health and development of the infants.
Thank you, Edmund, for adding these comments, and I fully agree. And that was also something I would like to add, because Angela, of course, you gave a summary within 40 minutes of 16 years of work, but actually there's a lot more work that has been done, and many more details of the studies that sometimes indeed are different between the two different networks. So you have not been able to touch upon, let's say, protein binding, for instance, so free concentrations, measuring metabolites, something else that is could be interesting in looking at the mechanisms of what is happening during pregnancy. I know Impact has a second trimester PK curve in some of their protocols, which we do not have, but it can give additional information. So these two protocols or networks are never 100% copies of each other, so there are different objectives sometimes, and that can even expand our knowledge on the work that has been done. I do have a question, Angela, to reflect on. So now we are 16 years more or less after we started Panna, but well, let's assume you would start Panna today. What would you do differently from 16 years ago? Is there anything you can share with us that you have learned, and that you would say, well, if it would be possible to do it differently?
Well, I think the general setup of the protocol is fine, but I think I would add a second trimester curve, and also the washout, what is also within the impact study. So we within Panna, it was a little bit more difficult to get approval for collecting samples from the infants after birth to check the washout in the infants after delivery. And if it would have been available then, we could. When we would start all over again now, I would definitely use this PBPK modeling to check for which drugs is it really interesting to collect, collect curves from 16 people, and maybe for some we only need to collect for a few people or a few or less samples, or something like that. So to get more informed study design based on modeling data you can have now. So that would be something I would do a little bit different, probably.
Yeah. Okay, thank you. Well, there's a question from Gareth in the chat, but she's reflecting on the more quite recent work on the breast milk feeding in healthy volunteers, and there's some debate on what is meant by healthy volunteers. So HIV infected women, stable on regimen, doing well, could be more seen as healthy volunteers. So I think you wanted to express HIV negative women, isn't it?
Yeah, but women not living with HIV, and also not with hepatitis C, because we're using TAF, and not using any medication that could interact with the medication we're giving. So some of them can also, have some other diseases, and the other way around, Garrett, you're right. The women living with HIV can be as healthy as people without HIV.
I can imagine, Angela, that for many people attending today, that they are a little bit surprised to hear that HIV negative women are willing to take medication during breastfeeding. So can you share some of your experience in including these women in our recent studies? Was that a problem, or how did you succeed in getting these women included? Can you say something about that?
Well, yes, of course. It's not easy because you have to find women who are willing to do that. And from the start, we started a year ago, and we couldn't find anybody because we had we published in newspapers, whatever, all over the country, and we found in a year time, we found one woman. Then we talked to people who know a lot about advertising, and we changed our website. So when you go to the www.pannastudy.com, you'll find two entrances, a Panna and Panna B. For the people who can read Dutch, the Panna B is also interesting. We gave the information in little more smaller bits, sort of frequently asked questions. What do you want to know? And we restarted just an Instagram run. So advertisement on Instagram. Do you want to help? Help out UMC looking for women who are breastfeeding. And click on this, and then we found women. So they are reacting now. I think we'll have at least 1 in 2 weeks who is really interested in participating. And I always ask them also, why do you want to participate? And most of them, they already also had to use or are using medicines during the breastfeeding period. So they said, well, I had really a problem finding information about that. So I really think it's really important to do this research, and I want to help other people to get that information, so that information is out there. And some also say, oh yeah, I'm really annoyed because nobody is doing it, and now I've got the chance to do it, to give something back, or to do this. Yeah. And usually they always take their children, so it's really it is nice for the unit who's doing the study as well.
No, but so apparently we really need a different approach of finding the women for this study from what we did within the original Panna study, of course, because that was related to physicians, nurses, that we know from the treatment centers, and now we are looking for the general public, and that really requires different approach. How to find them and how to convince them, and I think that's really a learning curve for us. But now that well, maybe other people can make use of that too. Yeah.
Hi David, this is Tim. I'll ask it. I just said to Angela, there's lots of positive comments in the chat about your presentation, so I'll let you scan them as well when you have time. It's very nice to see everyone appreciating the work that you've done. In terms of a question, and please again, everyone else on there, you can put your hand up, you can type it or put it in. But I think that bringing it back to the study design that David mentioned, that obviously the impact 1026S and the 2026 is very similar design. And you mentioned that, you know, even this adding the second trimester to the Panna. But one of the issues I've always found is that obviously all of the women are acting there as their internal control. So you sample during the third trimester, then postpartum. But what's always been different between studies and sometimes between arms is when you sample postpartum. So sometimes it's 2 weeks after delivery, sometimes 6 weeks, sometimes 12 weeks. So if we could somehow, and based on your 16 years of experience, where should we sample it postpartum so that we have the best comparison, whether it's between impact, Panna, or wherever? When does it return to normal? Because often I think if you sample early, sometimes you get different results if you sampled a little bit late because you haven't returned to normal. Bit of a tricky question, and maybe there's no right or wrong answer, but I just thought I would get your opinions before you leave us.
Well, I did present on it once at the PK workshop, I think, but then we only presented the Penta study, and I think we could do the analysis differently. So it's there is some PBPK modeling being done now. So using these computer models, you can already predict better what will happen after delivery. And when you think about what is happening during pregnancy pharmacokinetic wise, that's because of the hormonal changes, and the hormonal changes are back to normal quite quickly after delivery. So when you're looking at when we think that enzyme induction is the biggest problem, or enzyme inhibition, 4 weeks after delivery should be sufficient. But of course, the volume of the total volume of the hormone is not back to normal at 4 weeks after delivery. And what is also interesting, but so I don't have the truth, but I think from the modeling, from the PBP modeling that was done by the Belgian group, I think, they came up with 4 to 6 weeks after delivery would be a good enough period between delivery and the postpartum curve to have a normal, having the back to normal situation. But I was also thinking, what about breastfeeding? Things can be different when women are breastfeeding or not. So I think that's a whole different or new area to research about. So that's something Pharma and Impact could join data on, because we all have a lot of data postpartum and at different time points as well. We have done one for atazanavir. We have a few curves that were taken 4 weeks after delivery, and in the same woman 14 weeks after delivery, and there was no difference at that, for these 2 women we've got the curves from. So but that's very limited data. But you're right, I think that's a research question, and also is interesting for PBPK modeling.
It's indeed a very interesting question, Tim, and I think, as Angela mentioned, we did, let's say, preliminary analysis, but combining the data from the 2 networks, but then looking at all the different agents is quite a challenge. It's a large data set, and maybe not the impact of the time after delivery is similar for each of the agents. So it could be quite complex analysis also, but I think it's a good point, because that's really something we can learn from this experience, and maybe help other people. And that was also one of my additional questions, Angela. So this is all about HIV. People within Penta are doing more than only HIV. So if you first look at other infectious diseases, how could what we have learned here in pregnancy also be helpful for other infectious diseases relevant for pregnancy, or maybe even outside infectious diseases? Can you say something what you have been seeing over the last couple of years? What is changing?
Well, outside HIV, things are changing a bit. I think that there was when you look at hepatitis C, there was interest by a few parties to look at hepatitis C medication in pregnancy, use in pregnancy, and some PK studies have been done, but still the sort of appetite to do such a study, or to use hepatitis C medication, DAAs, in pregnancy is not that big for apparently pharma companies. So that there was some reluctance still, I think, to use medicines in pregnancy, because they say, oh, you can do it before the pregnancy starts or after they deliver, so you don't have to do it. But in general, I think for there is, within what I know, also within our department, we've got a project that's called Madame, which is is developing a pregnancy formulary. So to look at all the often used medications for any disease during pregnancy, what is known about pharmacokinetics, and which dose should be given during pregnancy. So there's and then they also use PBPK modeling sometimes to substantiate these doses they would propose. So that's I think that's a really interesting initiative. And also, I think in general, PBPK modeling in pregnancy and getting more information on how to model these, how to include these different factors and changes in pregnancy in the models in a better way, that would be really good. And I saw a sort of same question related to that in the chat. Whether you can also include different populations in this PBPK modeling, and that is possible. So for example, also when the UGT genotypes are different between the populations, that can be modeled into those systems as well. So that is an option, but I think that's still needs some more work.
No, thank you, Angela, for that comment, because indeed that was in the chat that people were asking, okay, is there any difference that you would expect from different populations? And I think that's also another aspect that we maybe also due to limited numbers relatively, we have not yet been able to really look at that because, well, normally we have 16 subjects in a study as you showed, or 20 maybe, and even if you combine the data from the two different networks, we still don't have that many different subpopulations to look at that more particular. While we know that of course pregnancy is much more common in terms of numbers in African women versus well, let's say Caucasian women. And so I think it's important also to be aware of that and what we try. So we're almost about to close this Penta Aperitivo, and I know Mark still wants to say something. Well, he will be able to do so, but after that, I think it's important that we close the session. Well, really thank you, Angela. But first, Mark, and then we will finalize this Penta Aperitivo. Mark, please go ahead.
David, I just wanted to say that you have to be careful with using PBPK models and look at the data that underpinning the model. And we have a collaboration with some modelers at FDA, and we were able to use our large database of pregnant people with HIV and we just took some of their common lab values, common values for hematologic and chemistry labs, and found that if that data was put into the model, it improved the fit for HIV drugs than with whatever pregnant population the existing PBPK model was using for something as simple as these common chemistries like hematologic and chemistry and hematologic lab values. So that makes me wonder about what about some other more complicated underpinnings of these models, like measures of blood flow and of protein binding and other things that change in pregnancy. And so I think there's a lot of work that needs to be done to make these pregnancy PBPK models fit better, which is good for the next generation of researchers. And I was just going to add that I'm confident that you'll do great in whatever you move on to. And again, I think it's wonderful to have someone with your background and expertise and approach and knowledge about these issues on the regulatory side of things. I worry more about David and how he's going to survive without you.
Well, Thank you, Mark.
Well, I'll give him an extra cup of coffee, and that will
yeah.
be okay.
Don't worry, Mark, but it will be different, that's for sure. And thank you very much for your kind words. And indeed, there's still a lot of research to be done. Of course, always new questions come up. Before we really close this session, I would like to thank also Elaine Abrams for her comment in the chat that this is not only about research and doing studies, but indeed also, Angela, you worked very hard, especially in the recent years within WHO and also together with Impact to advocate the research in pregnancy and also, of course, in children. So it's not only about doing the research and your own publication, but it's always also moving the field ahead. And I think you showed that really some things have changed over the last 16 years with pharma companies more active early during drug development, looking at these issues, and for sure that would not have been happening without your and also Impact's work on the pregnancy issues. So I think that's a very important impact that you have had and with others in the field.